Hello, welcome to the eCancer Roundup at ESMO. We're talking about melanoma and skin cancers, and joining me is Teresa Amaral. Nice to have you here.
Thank you for having me.
Okay, and among the many things that are being discussed at this year's conference, first of all, the surgical options for skin cancer management. If you could tell us what's come out of this year's conference.
Yeah, actually I have some new data that was already presented in ASCO this year, but actually it mostly tell us that probably not all patients need to do a complete lymph node dissection once they get a positive lymph node. And this is important because it changes the way we handle this kind of patients. Of course, it comes also the question whether this complete lymph node dissection will give us more information and it will give us an advantage in terms of survival. And these two studies, the DCOG trial and MSLT2 trial, show that there is no advantage in terms of survival. The thing is that we get a lot of questions whether if we get more information from the lymph nodes, can we better predict the survival from these patients? And actually there was a very interesting publication in the European Journal of Cancer that talks about the combination of the tumor burden in the sentinel lymph node and the ulceration of the primary tumor. And with these two informations that we get without the complete lymph node dissection, we can actually stratify the patients in three risk groups, and without any further information we can somehow predict the survival of these patients. So probably we don't need more information from the complete lymph node dissection. We can, with these two combinations, stratify the patients in these three groups, and probably you use this information for planning future trials in the adjuvant setting.
Then leads on to the news about the new classifications in skin cancer and melanoma.
Exactly, that it's also a new information or a new classification that we get. We had the previous 7th edition of the AJCC classification, and now we have the 8th classification, and there is a difference between these two that is mostly on stage 3 patients, and before we just had 3 groups, stage 3A, B and C, and now we have an extra group, and this poses some kind of challenges because all the previous adjuvant trials were done with the previous classification, and the results are based on this previous classification, and it might be difficult to translate these results into the new classification with 4 substages, and this is something that needs to be handled. Not exactly how we should handle that in the future, but it's an aspect that needs to be handled.
You mentioned adjuvant trials there. A lot of the data coming out of the trials presented this year's ESMO meeting are adjuvant and neoadjuvant data.
Exactly.
So what have been some of the highlights that you've seen?
So actually we need to separate these two settings, the neoadjuvant and the adjuvant setting. We have some advantages in the neoadjuvant setting that are the fact that we can monitor the tumor during the therapy, and actually different from other tumors, we do not just want to achieve the possibility of operating these tumors, we also want to bring the immune cells and the immune system to the tumor. And this is something that it's different from the chemotherapy that it's done in the neoadjuvant setting, and it's somehow special to the melanoma patients. In the neoadjuvant setting, we already had some data previous from the OPACIN trial, where they tested the combination, or they evaluated the same combination in the adjuvant and neoadjuvant setting. And we saw that actually this combination is effective in the neoadjuvant setting. The problem is it was very toxic. So, and it was a toxicity that was not tolerated and was not acceptable in this setting. So the trial changed a little bit, and we tested, or they tested, another combination. It's ipi/nivo, the same but with a different dosage and shorter time duration. And what we saw, and these were the data that were presented today, actually this is still effective. We still have a lot of pathological complete responses, but with a very lower toxicity, and this is very important in this setting. We also see that these pathological complete responses are very well associated with a relapse-free survival. it's yet to be seen if this translates in terms of overall survival or not, but for now it seems to be well correlated. Also from this neoadjuvant setting or from this neoadjuvant trial comes the information that might be a genetic signature associated with better responses, and these are the tumors that have a high interferon gamma signature. Then for the adjuvant setting, we had today the update from the COMBI-80 trial, which is a target therapy trial opposed to this immunotherapy from the OPACIN-neo. And last year in ESMO we saw the first data, and these data from today actually confirm the advantage from combination therapy opposed to placebo in patients with BRAF mutant melanoma and stage 3 melanoma. What was actually the new part of this presentation, or actually two new parts. The first one is that they presented a model that it's a cure rate model that, besides the information that we have from relapse-free survival and distant metastasis-free survival, somehow predicts or try to show us which percentage of patients will be cured if they are now without relapse, or if they are disease-free patients. And in this model, what we see is that the patients that have disease, that are now disease-free or relapse-free, have a 54% chance that they are cured, compared to 37% of the patients that received placebo. So it's an important aspect. The second important aspect is that for the adjuvant therapy, as I said, we do not have quite a genetic signature, a biomarker signature. And what they presented was that also patients with a high interferon gamma signature seem to have a better prognosis compared to the other ones. And also important is that the tumor burden, or the tumor molecular burden, seems to be a high tumor molecular burden seems to be associated with worse response to target therapy. So maybe these patients will do better with immunotherapy, we do not know, but this is a possibility that might be investigated in the future. So yeah, two questions remain to be answered in the BRAF setting, whether patients should start with BRAF directed therapy or immunotherapy, and also for the other ones that are not BRAF mutated, whether should we start with immunotherapy up front or should we wait until they relapse and then do immunotherapy afterwards. And this will be answered by the one trial that is ongoing with pembrolizumab that allows patients to receive immunotherapy if they relapse and were in the placebo arm, or if they received previous immunotherapy and they relapse after 6 months. So questions that need to be addressed.
Well, maybe one of the answers to these questions could be the triplet therapy then.
Yeah, actually we have also in the neoadjuvant setting, from the institution that I'm collaborating with, we have the possibility, or we are planning a trial where we test combination of immunotherapy and target therapy in the neoadjuvant setting. We have some data from the metastatic setting that was presented also today. The follow-up was too short, so we cannot actually draw conclusions from the combination of pembro and dabrafenib plus trametinib. And we are also waiting for the information from two trials that are ongoing. One where we have combination target therapy up front and then we add immunotherapy. This is the trilogy trial. And then the second where we had combination target therapy and immunotherapy up front in the COMBI trial. And it seems to be a difference between the patients that receive upfront the triple combination or the patients that started with the target therapy and then we add immunotherapy. Unfortunately, we do not have data from these trials that are still ongoing, but yeah, probably we'll have to wait a little bit longer to know if this is actually the path that we need to follow also in the neoadjuvant setting and not just in the metastatic setting.
Also, it sounds important to see if patients can tolerate that kind of treatment schedule.
Yeah, it's the toxicity. It's one of the points because actually, as I said, the toxicity it seems to be different if you do it the triple combination up front or if you do target and then immunotherapy. What we saw is that if we try to do it all at the same time, we see different patterns of toxicity. the immunotherapy toxicities are not different from those that we are already used to see from in the other immunotherapies, but the combination therapy has different toxicities from what we are used to. So it's difficult to see if we actually have survival benefits that outweigh the toxicity of the triple combination. It's to be known.
I guess time will tell.
Yeah, exactly. Time will tell.
Thank you so much for your time in talking with us today, and we look forward to catching up with you at another conference sometime soon. For everyone watching at home, then thank you for joining us, and we'll see you with more from ESMO soon.